From Dr. Lee.
Everyone hear me okay? Everyone, I just wanted to say it's a privilege and honor to be able to be speaking amongst such esteemed panel of speakers, as well as very kindred spirits in the audience. And so would love to be able to share a bit of the Landmark experience. So I'm Michael Lee. I'm the Chief Medical Officer and co-founder at Landmark Health. And Landmark is a mobile medical group that provides risk-based 24/7 in-home care for the sickest and frailest patients, partnering with risk-bearing entities. And currently we're in 10 different markets in 6 different states. And just wanted to be able to share a little bit of background about myself, because I think it does talk a little bit to the founding of Landmark and the mission that we have. And so I actually grew up in small town Massachusetts, where my dad was a primary care physician, and I actually watched him with his little black bag going into patients' homes. And that's really what hooked me on medicine, that sort of golden age of medicine. And we ended up moving to California and did my med school and internal medicine training in Southern California, and thought those Marcus Welby days were a thing long gone by in the past. And so I ended up going to work for a large medical group and was a hospitalist, and eventually ended up focusing on high risk patients. And so I would see patients in the hospital, would then discharge them to the nursing home where I'd follow them, and then see them in post-discharge clinic. And there was this small subset of patients that looked in post-discharge clinic, looked great, had their Sunday best on, makeup, well put together. But invariably, the small percentage of these patients would end up back in the hospital 2 weeks later, and it just really didn't make sense because they looked so good. And so I just thought, what the heck? Why don't I go see this patient in the home? And I know that for those of you who've been in the home, it's a very eye-opening experience. You go in there, you see the hoarding, you see the fall risk, you see the empty refrigerators, the lack of social and behavioral support, and then it's just that you really see the root cause of why that no one ever saw in the office, because in that 10 minutes in the office, they can hide a lot of stuff, but in the home, there's nowhere for them to hide, and you see all these root causes, and you address these root causes, and lo and behold, these patients get better. And so, that really is the essence of what Landmark does, is that, for the sickest and frailest patients, we can't make them come to the doctor's office, to the specialist's office, then to the lab, then to the pharmacy. It's just too much for someone who's got polychronic illnesses, as well as mobility challenges, lack of support. And so our model really is that for this sick and frail population, we need to bring the teams, the systems, the procedures to the patients and be available 24/7 to them, because let's face it, Monday through Friday working hours is really only a quarter of the hours of a given week. And so we need to be available to them to be able to make these interventions any time of day or night. So, we actually have coined the term complexivist, so hopefully someday it'll roll off the tongue like a hospitalist. But, it really is this sort of, this risk-based medical group that provides this sort of, this inpatient or the in-home care for these patients. And, it is very much about being able to do a lot of interventions, being able to get in front of that 911 call, treat these patients where they're at, and really make sure that that if we can stabilize them in the home and then partner with the community. So it's a model where, unlike PACE program, where patients have to give up their primary care physician, we come in as a partner, and we view ourselves almost more like a specialist, where our expertise, instead of being the heart of the lungs, is seeing the very valuable information in the home that no one sees, and then be able to share that with the PCP, the specialists, other people who are touching the patient, so that we can have the most comprehensive care plan for these patients. So when we were starting the business and we thought about the funding, I think everyone's talked about how fee-for-service and the sort of incentives are wrong for this sort of population of patients. And so we thought that there's all this. There's so many things that we wanted to be able to provide for patients, but we needed to have more of a sort of prepayment or capitated sort of model to be able to provide these services for patients. And so we actually partnered with health plans, and what we did, and I think the important thing was to take downside risk for the health plans. Because I think as we went across the country, we realized that a lot of the arrangements from the health plans with some of the medical groups were just upside-only agreements with really no downside. And so it does distinguish you if you are willing to take that sort of downside risk. And so we in essence, in partnership with the health plans, will identify a very sick cohort of patients. And so it's not always the most costly patient. Because sometimes you have a traumatic brain injury that needs rehab, or you have a patient who needs a bone marrow transplant or whatnot. But if you can find a population that's chronically frail over the long term and establish that as a risk sort of baseline, that's how we can set that sort of cohort and then measure against that population to take downside risk. And so if we can't save money for this population, we would end up paying back everything that the health plan gives us. And so in essence, these patients would get free concierge level care in their home 24/7, and the health plans should be none the worse for that. If we are able to generate savings, then we share that with the health plans. Other elements of the model is that once we identify the cohort, we take risk on the entire cohort, whether they engage or not. And so that way, you're not cherry picking, this patient has ESRD, or this one is a drug-seeking patient, or they have SMI. We'd rather not touch that patient because they're going to be a headache. If anything, they become more our opportunity, where they have the highest utilization, the highest cost. That's where the impact is. You're able to drive the impact. And so it incentivizes and aligns the incentives so that we go out and we try to take care of the sickest and most frail patients and get out to as many patients as we can. And also by identifying a cohort based on chronic conditions, as opposed to, let's say, 2 hospitalizations and 2 ER visits where there's a lot of regression to the mean, then it's a little bit easier to be able to identify the impact that you've had on the particular population. And so, we're able to get with the downside risk, we're able to convince the health plans that it's less risk for them, and so they can help to pre-fund and prepay for the program. And so what we did was kind of worked in reverse. We tried to figure out, for this population of patients, what's the ideal model? What's the end state that we'd like? What's the composition of the team, everyone that we'd want? So behavioral health is a big element of it, social work is a big element, pharmacist, dietitian. And then what ratios would you want to be able to get to a certain touch frequency for these patients? And then you have this model, and you can derive a PMPM per member per month, what sort of cost it would be. And then as you engage, the health plan pays for that. So that way you can then scale up and build up pretty quickly, because as opposed to having to bill and wait for the revenue later, it allows you to build up the population and build up the program fairly quickly. So this actually talks to the clinical pillars, and I know that, like in Eric's talk and others, it's very similar to a lot of the other principles that we've had. The complexivist model really is that high touch, high intensity care. So, our teams are comprised of docs, NPs, PAs. We also have behavioral health, so we have psychiatrists, psych NPs, addictionologists, especially for our Medicaid and duals populations. And then a full interdisciplinary team, so nurse care managers, social workers, pharmacists, dietitians, all with very small patient panels, so you can have very high touch. So initial visits, hour and a half long, follow-up visits, 45 minutes long. So you have that extra time, that time to spend on the porch to really get to know the patients well, and get to know their baseline well, so that if patients, if you really know their baseline well, you may notice that today their color just doesn't look quite the same. They're a little less verbal. They're having more difficulty with transfers. You may not know what's going on, but you can investigate and really do kind of figure out that UTI before it becomes urosepsis, or the early fluid weight gain before it becomes florid heart failure. But also, I think a differentiator in a way for Landmark, because of the prepayment, is that it is 24/7 in-person care in the home. And so we provide our teams a lot of training on procedures, and we have call schedules to be able to be available in home in the patient, with the patients 24/7. So at 2:00 in the morning on a Saturday, you could be there, and we have iStat machines to check labs on site. We can order mobile diagnostics, x-rays and ultrasounds in the home. Can start IVs, give hydration, carry Lasix, Rocephin, Solumedrol, Levaquin, insert catheters. So really a lot of interventions that would otherwise probably normally be done in an urgent care emergency room to try to stabilize them there in place. Because I think, as we all know, once this 80-year-old patient with multiple chronic conditions gets to the ER, game's over. That patient's going to get admitted and be subjected to all the risks that are associated with that. So a very, very high touch model. Behavioral health, it's, we certainly, as we did the analysis, probably more than 50% of the patients have some behavioral health comorbidity, oftentimes underdiagnosed and certainly undertreated. And the community resources are so scarce that sometimes it's, weeks or a month before they can be seen. And by then, this schizoaffective patient or the bipolar has spiraled well out of control. And so we actually have, one of our very early hires was to hire the chief medical officer from Value Options over to be able to run a team, run a team that of psychiatrists, addictionologists, psych NPs, social workers, really to integrate and marry medical and behavioral as much as we can, because a lot of times it's there's a negative impact on quality and cost for these patients if their behavioral needs are unmet. From a palliative focus, I think very, very passionate about that. And I'll tell you, as a hospitalist, there's no worse place to have that first advanced care planning discussion than 1 a.m. in the emergency room or the ICU. And there's really no better place than sitting in their living room, surrounded by their family, with an hour and a half to talk about all of the issues that need to be addressed, answer all their questions, and get everyone onto the same page. And so we actually, we do a lot of training up front in our Landmark Academy on we've built video modules on how to have challenging conversations, how to introduce hospice and palliative, how to fill up MOLST and PULSE forms. And really, even in our EMR, we've actually mandated by the third visit, you have to have documented advanced care planning discussions into the chart, and it has to be updated at least on a yearly basis. And we'll get into some of the results on the palliative and hospice side a little bit later in the presentation. And then the fourth pillar is, if we came into the market and said, hey, we've got this great program for you, it's free, it's 24/7, but you got to give up the doc that you've had for the last 30 years. It gets to be a difficult decision for the patients. And so, so we didn't want that sort of barrier to entry into the markets. And we think that there's a lot of value in that PCP relationship. And so we actually come in and we say we're more like specialists, and that, we collaborate and we communicate with the PCPs, and we make sure that they're getting all the information, we're picking up the phone and calling them. But it is something where, I think the PCPs can see value, because sometimes these patients are the ones that are not getting into the office, or when they do, they need to call 911 because they're coming in crisis. And so I think they appreciate having, and again, it's not a blanket statement, not everyone is completely satisfied, all PCPs are completely satisfied, but a lot of times that they see that you can do some of the heavy lifting, you can have some of those challenging conversations, and they don't want to have to go out to the home in the middle of the night. But if they know they can call you, you can go assess them and call them back with what you're seeing. I think they appreciate that sort of service. So, we feel fortunate, and I do think that there is an environment. The environment is right now where a lot of the health plans are very open to innovation. They're very open to being able to, take in groups that are willing to take risk. And so, Landmark started about 4 years ago with 4 people literally sitting around a table at Panera Bread with, writing out notes. And we feel fortunate that, in October 2014, we launched our first contract with one of the Blues plans in New York. And since then, I think because of taking risk, it does differentiate you. And then, we've been able to sign 8 other health plans and launch in 10 different markets. And so you can see that right now we have about 45,000 members under risk across the country, across all lines of business: Medicare Advantage, Medicaid, duals, commercial. Vast majority still Medicare Advantage, but you can see that 94,000 home visits in the last since inception, and it's very well received by the patients. Over 50% engagement. And so the value proposition is there. The toughest thing with engagement is just getting the right contact information to be able to reach them. Because once you get through to them, I think most people are pretty interested, especially if they've been in the hospital several times. And the engagement is important to us because, again, we have risk on engaged or non-engaged. So the more patients we touch, the better. And I think interesting thing about 20% of our visits are unscheduled urgent visits, so either after hours or weekends. So there is a big need to be able to have that capability to be able to, because if we can send someone out in the middle of the night and avoid a $10,000 to $15,000 hospitalization by giving them some interventions in the home, it's very much worth it for us. So what are some of the results that we've been able to impact? So obviously quality is something that's very important to, not just to us to improve the quality of our patients' lives, but a lot of our health plans have STARS and HEDIS measures that they need to be able to hit. And so, this slide shows, some of the quality measures that they asked us to really focus on in the contracts. The actual is what this population was pre-landmark. And so you can see, some of them were 1-star, 3-star, 4-star, and then they would set a target, usually 5 to 10% above that, expecting that we should do better. And you can see that by being able to be in the homes, by being able to go through all of their medication bottles, counting pills, really reinforcing behavior change and sometimes just pestering them to do things, we were able to significantly impact quality measures, especially on those control measures that are very difficult, from controlling blood pressure to controlling A1C. So, and patient satisfaction, patients are obviously very, it's free concierge level care to the home for them 24/7. So I think, they're very satisfied with not just the service, but the time that you spend in answering the questions. So also, the biggest driver of cost is really inpatient admissions. And so when we look at it, this is data from comparing the 2014 pre-landmark baseline to the results in 2016 composite of our upstate New York experience. You can see that on the percent difference column is the difference on the entire cohort, so engaged and non-engaged. And so in the beginning, your engaged population is smaller. As time goes on, it's a higher proportion. Plus, you've had more time to really reinforce, call us, we can be there, educating them about the trigger so that they can identify things earlier, so you can treat them earlier before it gets to a significant stage. But you can see that, when you adjust on the engaged population, total cohort, up to 20-something% reduction on the entire cohort. You can, as you look at just the engaged impact, 30, 40, 50% impact on the admissions. So, and then that's not just the admissions, but those patients that are in the hospital end up going to the nursing homes. They end up having specialists and other sorts of costs and potentially procedures that may or may not be beneficial for them downstream. And so when we look at medical loss ratio, these patients typically are 110, 120% medical loss ratio, so health plans are losing money on this population of patients. What we've seen over the past couple of years is, we're in the home 12 times a year on average, monthly. We're capturing HCC diagnoses and diagnoses for patients also. And when you look at that sort of combination of, the utilization reduction from the hospital, the SNF, the pharmacy, and then you combine that with the impact on revenue. In the first year, we saw a 25% reduction in medical loss ratio and 37% into the second year. So these patients that were starting at 110% medical loss ratio are now down into the 80s. And so in the beginning, the health plans didn't necessarily want to advertise the program because, why select a patient population that they were going to more money losing patients to that plan? Now they're seeing that these patients are becoming profitable. So now they're asking, can we do like a D-SNP, or can we do an I-SNP, or looking at other ways to attract patients into this sort of area. So, again, if you can show the return, I think there generates a lot of interest. In terms of palliative end of life, again, we do a lot of focus on it. We do a lot of training. And in our early markets in upstate New York, the utilization in terms of average length of stay was quite poor. Less than 20 days average length of stay. By mandating those sort of conversations, by training our staff to how to have effective conversation, plus in our weekly in-person meetings, we invite the local hospices to come by and participate. Because oftentimes, if they're seeing the hospice personnel in the meetings, it keeps it top of mind. Oh yeah, maybe I should think about hospice for this patient. And so we've been able to, one, increase the percentage of patients passing away in hospice by almost 2 times, and then significantly increasing the length of stay, so that patients, instead of just having that 2 weeks benefit, they get much more significant benefit for it. And frankly, some patients will never sign up for hospice, in which case, because we have this in-home capability, sometimes we do end up providing very hospice-esque care, crisis sort of intervention daily to the patients in the home. And I think one of the interesting things that we looked at was that we thought that our patients would be living longer. One, because you're avoiding hospitalizations where they could catch infections and other complications. Two, by trying to do end of life better. So what we looked at was engaged versus non-engaged and what the mortality rate was for this population. And the interesting thing is that for the engaged population, there is natural selection bias. Patients who are sicker will embrace the program much earlier. So the actual RAF score, the risk score of these patients at the time of engagement, was higher for the engaged by 2.48 versus 2.1 for the non-engaged. And yet still, even though it was a sicker population that was being selected, the mortality rate dropped by about 17% for this population. So, we're doing some propensity match cohort analyses to try to isolate and see. We expect that might even grow more once we match the cohorts. But, these patients are living longer also. And in terms of, again, I think it goes without saying that if you're providing this sort of service, patients are very happy with that. And so, a net promoter score of 91%. And the interesting thing was that for a mailed survey that we sent out, 50% of patients actually took the time to return the mailed survey. And so our third-party surveyor said, typically we get, 10, 15% response rate, but we had 50%. And one of a very rewarding thing that I experienced was I had a letter addressed specifically to myself. And inside that was the survey wrapped inside of a handwritten letter of what the program meant, how much they loved their provider, and what a difference it's made in their lives. And so, it's a bit of a different quadruple aim, but patients are living longer, better quality of life, lower cost, and with a great patient experience. I think we struggle with what I'd call, I guess, the fifth one, which is the provider sort of experience, burnout, retention. I think it's not an easy job, and I think finding the right person is the key for this sort of model. And so I think we're still working. I think that's always going to be a work in progress. And so I think it's very much appreciate the opportunity to speak about home-based medical care, because I think that there's such a great need for it, and there's so little supply of this, and there's so much more need than what is out there. So the more that we can try to promote this to anyone that's listening and get people engaged in it, we're happy to do that. And just some policy asks. I think if there is possible to have advanced physician group models that allow for more risk-taking to be able to be done directly, accepting full risk by medical groups that are able to financially do so. I think that creating full risk polychronic ACOs, similar to what they've done with ESRD, a plug for Eric. We'd love to see expansion of independence at home also, and I think PACE is also very interesting. Although we would promote like a PACE without walls, without the sort of requirements for a physical center, and be able to do that more remote, kind of as a home-based model instead. Thank you.
Thank you very much.